there in person. I am actually on the internal medicine service now, so I can't travel, admitting patients to the hospital. So, um, talking about short course antibiotic therapy, when I give this talk, um, I always like to start by reminding people why this is important. Antibiotics are the most effective life-saving interventions in medicine. This table here shows you the absolute death rates of infections before antibiotics became available and after. And so these are not relative reductions in death. These are absolute reductions. And, you got numbers needed to treat to save a life of less than 2. There's very few things in medicine that do that. One of the ones that is most surprising to people is actually um, this line right here of skin infections. In the pre-antibiotic era, 1 in 10 people with a simple cellulitis went on to die, which is insane when you think about that. That's based on an analysis of 29,000 patients from before antibiotics. In 1988, the ISIS-2 study was published. This was a randomized, placebo-controlled, multi-centered international trial of aspirin or streptokinase for myocardial infarction. What was the mortality rate of myocardial infarction in the placebo arm in 1988? 12%, which means that before antibiotics came along, a simple skin infection was as deadly as a heart attack, and antibiotics are much more effective at reducing death from skin infections than clot-busting drugs are from reducing death from MIs. Very few people remember this. This is not a commonly appreciated thing, but this massive reduction in death for individual infections explains these data. These are population level death rates in the United States. At the level of the population, as soon as first sulfa came along and then penicillin came along, there were absolutely massive reductions in death from infections in the United States. The reductions were so big and so fast that by the time the 1950s rolled along, this is the decade that introduced all components of critical care medicine, ICU medicine, mechanical ventilators, central venous catheters, pressors. Those interventions mediated almost no further reduction in death from infections. That is how powerful a transformation it was when antibiotics became available. The problem, of course, is that the more we use these drugs, the less effective they become. And as we overuse them, we risk causing the mortality rate from these infections to go back up the mortality curve, losing all the gains that we achieved when the antibiotics were first introduced. In fact, the concerns about wasting antibiotics go back to the very first days of antibiotic use. Within a year of widespread commercially available penicillin, the person who discovered penicillin was warning the public that doctors were wasting it on patients who were not going to benefit. And in his words, the people who were wasting penicillin would be, quote, morally responsible for the deaths that ensued. That was 80 years ago. We have barely advanced this discussion on appropriate antibiotic use in 80 years. 80 years later, we're using more antibiotics than ever. We're using broader spectrum antibiotics than ever. In the United States, surveys show that half of hospital use of antibiotics is unnecessary and inappropriate. And for some infections like UTIs, 80% is unnecessary or inappropriate. And that's with requiring prescriptions for use of these drugs. So something needs to change in how we approach the appropriate use of these drugs. And one idea for how to change doctors' use of antibiotics to make our use better was brought up by Dr. Lou Rice in 2008, now 17 years ago. Hard to believe. Dr. Rice really is the first person who started talking about the potential of short course antibiotic therapy to improve appropriateness of use and decrease selection for resistance. This was during a keynote lecture at a national ID meeting. He said that, look, it's really hard to get doctors not to prescribe antibiotics at all. Yes, you don't want them prescribed for viral infections or non-bacterial infections, but you don't win a lot of those arguments. Maybe we would win more of the arguments. Maybe it would be easier to convince doctors to prescribe antibiotics for only as long as is necessary to cure the infection. And he also pointed out that if you only focus on people who didn't need the antibiotic, like I said, you'll lose most of those arguments. You'll win a few. You won't do anything to benefit the patients that actually really did need the antibiotic. They actually did have a bacterial infection, but they didn't need an antibiotic for 2 weeks. And he pointed out that if you focus on the duration of therapy and shortening the duration of therapy, you will help both the patient who needed the antibiotic. They're going to be much better off with 3 or 5 days than 14 days of antibiotics. But you're also going to help the patient who really didn't need the antibiotic in the first place. He pointed out, look, would you like those patients to get no antibiotics? Sure. But they're still better off, and society is still better off if they only got 3 days rather than 14 days. So that was the origin of what eventually became the shorter is better movement. But the movement became branded with the name shorter is better with the publication of this editorial in 2016. This editorial accompanied a randomized controlled trial, the results of which I'm going to show you in a few minutes. In this editorial, what I sought to do is answer the following question. What is the evidence basis of 7 or 14-day courses of antibiotics? What's that based on? What studies? What's the data? I looked in guidelines. I looked at the references. I looked at the references of the references of the references and traced it back in time. And it turns out the evidence supporting a 7 or 14-day duration of antibiotics is the fact that in 321 AD, Constantine the Great decreed there would be 7 days in a week. That's why doctors give 7 to 14-day antibiotic courses. If good old Constantine had decreed a 4-day week, we'd be giving 4 to 8 days of antibiotics, and there'd be a lot less antibiotic resistance in the world. And also, there'd only be 2 work days before the weekend, and that would have been really nice. But he didn't say 4 days in a week. He said 7. So when I'm rounding, and my residents ask me, how long should we treat this infection for? I'll say something like, how about we give 1 Constantine unit instead of 2? I call them Constantine units to underscore how absurd it is that this is the evidence we're using to make treatment decisions in the year 2025. Now, to be fair, not everybody uses Constantine units. There are people who believe in 10-day antibiotic courses. They don't use 7, they don't use 14, they use 10. What's the evidence for the 10-day course of antibiotics? And it turns out the evidence for that is the number of metacarpal bones that evolved in the hominid hand. I'm sorry, that's the sad reality and truth, which is what led several co-authors and I to publish in a peer-reviewed article that the world might be a better place with diminished antibiotic resistance if we had instead evolved as 3-toed sloths. Now, I will say that one of the peer reviewers of this article did not like that sentence and insisted that it be removed because it was deemed, quote unquote, unprofessional. So my co-authors came to me and said, oh, that's a shame. That was a funny line. We need to take it out. And I said, are you people crazy? That's the best line in the whole paper. I'm not taking that out. So I called the editor. And I said, look, this is a true story, by the way. I'm not making this up. I called the editor. And I said, look, you knew I was crazy when you asked us to write this article. And he goes, and he said, I swear, he said, I'm not making that. He goes, actually, I asked you to write the article because I knew you were crazy. So I said, so can we leave this line in? And he goes, sure, leave it in. And that's how it made it through peer review and is now indexed on PubMed. Now, I gave this lecture to the Massachusetts ID Society several weeks ago. And in response, they shipped me, and again, I'm not making this up, a stuffed 3-toed sloth toy, which you can see pictured here, as a token of thanks. And so they said the name of this sloth is Stephen, and that I should show the Stephen sloth in all future lectures. So that's why you see an image of my new pet sloth, Stephen, in this slide. Now, shorter is better has evolved beyond sort of a radical idea, and it is now mainstream. It only took 15 years to get there, but it is now mainstream. The American College of Physicians, which is the largest specialty society of physicians in the United States, has published a position paper that short course therapy is now standard of care for many types of acute bacterial infections. It's actually really hard to keep track of the diseases and trials in this space. There have now been more than 140 randomized controlled trials comparing short durations of therapy for long durations for all of these types of diseases. And these trials come out so fast that review articles are out of date a year or two later. So I keep a running a tabulation of them on my website as shown here so that it can be kept up to date in the public domain. I don't have time to go through all 23 disease conditions, so I'm just going to go through sort of the more common bacterial infections that we encounter in hospitals. And we'll start with community-acquired pneumonia. There have now been 14 randomized controlled trials of durations of therapy for community-acquired. How many do you need? Are you like, well, if you had 15, I believe you, but 14? So like, yeah, 14 trials of nearly 9,000 patients, all of which showed 3 to 5 days of antibiotics is as effective as 10 to 14 days. This is revolutionary. When I was a medical student back in the Cretaceous era, when I used to ride a Brontosaurus to work in the morning, I was taught 14 days of antibiotics for community-acquired pneumonia, and everybody knew that. And now we know that was dead wrong. 3 to 5 days is the appropriate duration of therapy. Now, one of the original complaints of the first 4 to 5 of these trials is that they were largely non-severe pneumonia, outpatient pneumonia or ward level, non-ICU level pneumonia. That changed with the publication of the 2016 trial, which my editorial accompanied that we just went over. And we're going to go through those data in a minute. In many of these 14 randomized controlled trials, the airway was sampled at end of therapy. And not surprisingly, whenever that was done, there was less antibiotic resistance in the patients who were treated with shorter courses of antibiotics because, you know, natural selection and stuff, that's how it works. You expose the bacteria to longer durations of therapy, you will select for more resistance. So this is the Uranga trial from 2016, which was the first trial that did enroll sicker patients with pneumonia. 40% of the patients randomized had pneumonia severity index scores of 4 or 5, the sicker patients with pneumonia. And you can see that in this trial, across all endpoints evaluated, no matter what the endpoint was, no matter what population was looked at, there was no difference in outcome between the two arms. And again, additional analyses, no difference, no difference, no difference, no difference, no, except for one population. There was one population which had a different outcome between the two arms in this trial. And guess which population that was? It was the pneumonia severity index 4s and 5s, the sicker patients with pneumonia, who did statistically significantly better with short course therapy. And so when this was published, people came up to me and they said things like, well, that doesn't make any sense. That would mean antibiotics are bad for you. And I was like, yeah, that's what it means, because they are. We have this magical thinking around antibiotics that they're like manna fallen from the heavens. They do no harm and only do good, but we know that's not true. Prospective studies have shown that every day you continue an antibiotic, you increase the chance of an adverse event by 4 to 5% absolute. And that's not even to mention the impact on selecting for resistance. Now, which patients in the hospital are more likely to get the acute kidney injury, the hepatotoxicity, the C. diff infections, the pseudomonal superinfections? It's the sicker patients in the hospital are far more prone to these adverse events. This result actually makes perfect sense. What it is showing us, and what the 14 trials in aggregate are showing us, is that every day you continue an antibiotic for a patient with pneumonia, you decrementally add to benefit and incrementally add to harm. And the question is, where do those two lines cross? And the answer from 14 randomized controlled trials is somewhere between days 3 and 5 of therapy. How much are we overtreating? People forget the daptomycin experience. When Cubist was developing daptomycin, they basically wanted to put it in the drinking water. They wanted a $1 billion drug that was used for everything. So they did 2 phase 3 pivotal randomized controlled trials for community-acquired pneumonia, having never studied it in a mouse model for pneumonia, which maybe they should have done. They learned from the 2 phase 3 trials that daptomycin was not effective for the treatment of pneumonia. Oops. They then went back to the mouse model, and that's when they learned from the mouse model, after they had done the clinical trials, that pulmonary surfactant inactivates daptomycin. That might have been good to know before you shelled out 50 million bucks for 2 randomized controlled trials. But they didn't know it. So they did the trials. And here's the important point for today. To make the 2 trials enrollable, they allowed a single dose of ceftriaxone before patients were randomized to daptomycin or continuation of ceftriaxone. And they then, after the failure was noted, did a post hoc analysis where they looked at patients in the daptomycin arm who did get a single dose of ceftriaxone and compared them to those who didn't. And those who got a single dose of ceftriaxone had a significant advantage in clinical cure. 1 dose of ceftriaxone probably cures 40% of patients with community-acquired pneumonia, and we've historically treated for 14 days. What about ventilator-associated pneumonia? Now, these are the sickest patients in the hospital with the most resistant organisms in the hospital, and they have a foreign body in place in that endotracheal tube. And yet we have 3 randomized controlled trials showing that 5 to 7 days is as effective as 10 to 14 days with reduced emergence of resistance at the site of infection. You no longer need 2 Constantine units to treat a ventilator-associated pneumonia. 1 is adequate, and in patients who are doing really well, we now know that 5 days is adequate for a pneumonia, for a ventilator-associated pneumonia. Now, I really like this study. I find this study endlessly amusing. This is not a randomized controlled trial. It is a retrospective study from a Harvard hospital, which actually adds to the amusement for me. A retrospective study of patients who had, quote, suspected ventilator-associated pneumonia. Now, what was suspected pneumonia? What does that mean? They looked at patients who grew bacteria from their secretions, their lung secretions, and for whom doctors started antibiotics. That was their definition of a suspected ventilator associated. They were on a vent and they grew bacteria and they got antibiotics, they had a suspected pneumonia. And they looked at those patients who were oxygenating normally. They were not hypoxic. They were on FiO2 40% or less, and they were on low PEEP, but they still had suspected pneumonia, which is kind of weird. And they asked the question, did patients do better if they got more than 3 days of antibiotics or 3 days or less? And the answer was there was no difference in outcome, no matter what outcome or population was looked at. So the author's very amusing conclusion to me was that in patients with suspected pneumonia who are oxygenating normally, you don't need to give more than 3 days of antibiotics. I have no idea how this conclusion got past 3 peer reviewers and an editor, but it did. Here's my conclusion from this study. Patients that don't have pneumonia don't need more than 3 days of antibiotics because these patients didn't have pneumonia. They were oxygenating normally. But I will go back to the point that Lou Rice made in 2008. If you're going to give patients who don't have infections antibiotics, at least do us the courtesy of doing it for a brief period of time, and I will still chalk that up as a win. Now, there actually are 12 randomized controlled trials of complicated urinary tract infections, including kidney infections. The 12th trial I'm going to show you separately because it's a source of considerable confusion. The first 11 randomized controlled trials in this space, nearly 3,000 patients, show that 5 to 7 days of antibiotics is as effective as 10 to 14. This now does include both men and women. It's no longer just in women. and it includes both Bactrim and the fluoroquinolones. And so people say to me, yeah, but my patient's diabetic, so I need 2 Constantine units. And I say 40% of the patients in these trials were diabetic. They did just fine with 5 to 7 days. And then people say, yes, but my patient is bacteremic, so I need 2 Constantine units. 10% of the patients in these trials were bacteremic. They did just fine with 5 to 7 days. So you don't need two weeks of antibiotics for a kidney infection, even if they're diabetic or even if they're bacteremic. 5 to 7 days is adequate. So you had 11 trials showing the same thing. And then the 12th trial was published. This trial is called ProstaShort, and it was a source of considerable confusion. And people, when it was published, said, see, I told you you can't use short course therapy for kidney infections. And I was like, calm down, calm down. There are 11 other trials that say you can. So let's take a closer look at this trial, because it turns out there are 3 substantive problems with this trial. First is the name, ProstaShort. Now, when you call a trial ProstaShort, obviously you're thinking, all right, they're studying prostate infections, right? That's why ProstaShort, right? But if you look at the methods, what they were studying was men who were having fevers with the urinary tract infection, excluding prostate infections. The methods say they tried to exclude I don't know why is this like when you call a tall person shorty? Is this an ironic name? How did they come up with this name? It is very confusing to people. I don't understand this. Okay. That's problem number one. Okay. Here's problem number two. They used ofloxacin, which I have actually never prescribed. I don't know how often it's used where you guys practice, but it was largely replaced around 30 years ago with a drug called levofloxacin. Now, why is levofloxacin called levofloxacin? It turns out ofloxacin is a mixture of 2 enantiomers, the L and D enantiomer, and all of the antimicrobial activity in ofloxacin is in the L enantiomer. And when the manufacturer learned this, they wanted to refresh their patent. So they came up with a manufacturing method to purify the L enantiomer, got a new patent, and put it back on the market as levofloxacin. Now, I don't know about you, but when I dose levofloxacin, I give 750 milligrams per day. They were giving ofloxacin at 200 milligrams twice per day, which is a levofloxacin equivalent dose of 100 milligrams twice per day. It's a hilarious dose. Hilarious dose. I don't understand. Anyway, that's the second problem is they used a ridiculous dose of a drug that very few people use anymore. And then the third problem with the trial is the primary endpoint for success. They used the FDA endpoint, and people have been telling the FDA for a very long time that it's a stupid endpoint, but it remains the FDA endpoint, so that's what they used. The endpoint requires 3 things to be successful. The patient's symptoms have to go away. They should not have recurrence of symptoms. And here's the problem. You also have to have a negative urine culture at test of cure. Now, I don't know about you, but when I treat people with infections and their symptoms are gone, I don't do random cultures on them later to see if they still have asymptomatic bacteria in their urine. But that's what the FDA requires you to do. So here was the outcome. In the short course arm, their treatment success was significantly less. And everybody's like, oh, we can't use short course. And I was like, remember, there are 11 other well-done trials that say you can. So why does this treatment success lower in the short course therapy arm? There was no difference in clinical success. There was a 96% clinical success rate with the dose of levofloxacin equivalent 100 BID, which is amazing. There was no difference in relapses. The entire difference between the 2 arms was driven by asymptomatic bacteriuria in cultures taken 6 weeks after therapy, which is stupid because why would you do that? So here's the thing. The conclusion from this trial really should be, yeah, you're going to do just fine if you use a reasonable drug at a reasonable dose in men who have febrile UTI. And stop checking for asymptomatic bacteriuria 6 weeks later because it's ridiculous and unnecessary. Now, intra-abdominal infections. There are 3 randomized controlled trials showing that 4 days post-source control is as effective as 8 to 10 days post-source control. There are actually two trials of complex appendicitis, perforated appendicitis, showing even 1 to 2 days post-source control is effective. And then people say to me things like, well, that's crazy. My patient has a 10-centimeter abscess in their abdomen. You're saying to give 4 days? That's not what I said. 4 days post-source control. So then people say to me, well, how do I know when the source has been controlled? And my response to that is to paraphrase the late, great United States Supreme Court Justice Potter Stewart, who said about pornography that it's hard to define, but you know it when you see it. And that's how I define source control. You have to decide when the source has been controlled, and when you've achieved that point, 4 more days is adequate based on 3 randomized controlled trials. We've talked about ventilator-associated pneumonia. We've talked about urinary tract infections. We've talked about intra-abdominal infections. Those are the 3 places gram-negatives come from. So maybe it's not surprising that completely separate from all the trials we've talked about so far, there are actually now 4 randomized controlled trials of patients with gram-negative bacteremia of any site origin. We're going to talk about the first 3 first, and then I'll mention the 4th trial separately. The first 3 trials was more than 1,300 patients randomized to 7 versus 14 days. A third of the patients in these trials had active malignancy or had undergone transplant, and every type of gram-negative bacteria you can think of was included, including Pseudomonas and other non-fermenters. And in all 3 trials, there was no difference in outcome between 7 and 14 days. Now, these trials are now matched with the BALANCE trial, which was the most important. It's now 4 trials. It's the most important because there was 3,600 patients in this trial alone. And it was all types of bacterial bloodstream infection except Staph aureus. So it included gram-negatives, strep, enterococcus, but no Staph aureus. And most of it was gram-negatives. 10% of these patients had Pseudomonas. In this very large trial, and half the patients were enrolled from the ICU. These were very sick patients. In this trial, there was no significant difference between the 7 and 14-day duration, but actually the trend on mortality favored the short course therapy. There was not too far off it was close to statistical superiority of the 7-day regimen. 7 days was certainly not less effective and may actually have been more effective. For skin infections, which include cellulitis, major abscesses, and wound infections, we have 3 trials showing that 5 to 6 days is as effective as 10 to 14 days. And we even have trials of bacterial meningitis, okay? Here's a 1,000-patient trial of patients with bacterial meningitis. I'm going to show you a meta-analysis in a minute of 5 other smaller trials. 5 days of ceftriaxone was as effective as 10 for bacterial meningitis. You're telling me I can treat bacterial meningitis with 5 days, but I need 2 weeks for a cellulitis? Come on now. Come on. Here's your meta-analysis of 5 smaller trials showing exactly the same thing. Even bacterial meningitis can be treated with short course therapy. Now, for osteomyelitis, people often suggest this is an exception. It's not. We used to treat chronic osteomyelitis with 12 weeks of therapy, and we now know from 2 randomized controlled trials of vertebral and diabetic foot osteo, you don't need more than 6. 6 weeks is as effective as 12. There are smaller trials. These are 30, 50 patient trials, suggesting that in patients with debridement, you may actually be able to get to 3 to 4 weeks. And I'm hoping at some point someone does a larger definitive trial, because maybe we can even come down from 6 weeks, but we need the definitive trial for that. This is the point in the talk where the infectious disease experts stand up and begin throwing rotten fruit and vegetables at me, because I'm going to tell you that you don't need more than 3 days of antibiotics to treat acute exacerbation of bronchitis, chronic obstructive pulmonary disease, or sinusitis. And the ID doctors are going to stand up and yell at me, of course you don't need more than 3 days. You don't need any. These are viral infections. And yes, that's true. But again, I'm going to go back and invoke Dr. Rice. If you're going to give patients who don't need antibiotics, at least do us the courtesy of doing it for a brief period of time. I will still count that as a win. Now, for this group, which is a cancer focused group, this study may be the most important study of the day. This study blew me away when it was published. This is a randomized controlled trial from multiple sites in Spain of neutropenic fever. And it wasn't just any neutropenic fever. To be enrolled, you had to have an active heme malignancy or be status post stem cell transplant. These were the highest possible risk neutropenic fever patients. They were randomized to receive the traditional duration of therapy, which is that you had to stay on antibiotics until you were afebrile and your neutrophils came back. So you had to wait till neutrophil recovery, or the shorter course duration. And the shorter course duration was you could stop when the patient was afebrile for 72 hours and hemodynamically stable, even if their neutrophils were still not back. Guess what they found? There was no significant difference in mortality between the two arms, although numerically, the mortality was lower in the short course arm. What there was a massive difference in serious adverse events. More than double the rate of serious adverse events in the standard therapy arm, driven by superinfections and C. diff. Again, which patients in the hospital get your Pseudomonas and your C. diff? It's the sickest patients in the hospital. This result makes perfect sense. Shorter is better because it's as effective and less harmful. Now, we even have a real world cohort study that followed the how long study. They applied the how long criteria in a real world setting to 440 patients and then used 500 historical controls. And importantly, in this cohort study, half the patients that got the short course arm didn't just have neutropenic fever, they were actively bacteremic with neutropenic fever, and they still applied the how long criteria. And the patients in the how long cohort had statistically less death than the traditional duration of therapy. Now, let's talk about more complex situations. Tuberculosis is often described to me as an example of an exception to shorter is better. It really isn't an exception. It's just very complicated. We know from recent randomized controlled trials that our historical durations of treating latent tuberculosis are no longer required to be 6 to 12 months. We have effective regimens for latent TB that can be 3 to 4 months. Pulmonary TB used to be treated for 3 years. And then rifampin came along and it was 18 months. And then PZA came along and it was 6 months. So we've already achieved shorter durations of TB with better drugs. And now we have drugs like bedaquiline and delamanid and linezolid that are starting to move us. And there's some concern that 2 months may be too short. They're starting to move us towards 3-month regimens. So I think in the future, we will see that 6-month number come down. We are moving towards shorter durations of therapy for tuberculosis. But there actually are real exceptions. There are definitive exceptions from randomized controlled trials. 2 years ago now, the DTIPO trial was published of patients with prosthetic joint infections. And very clearly in that trial, if you retained the implant, if you did not exchange the implant out, 6 weeks was clearly inferior to 12 weeks. That is a legitimate exception. Otitis media in children under the age of 2 from a very large randomized controlled trial, 10 days was superior to 5. However, I will point out otitis media in children over the age of 2, less than 10 days is effective. So it depends on the age of the child. Now, why that is not clear to me. I don't know if that's anatomical because of the eustachian tube and it changes as kids age, if it's pharmacokinetic, if it's adherence, I'm not sure why. But I'm pretty convinced from the very large trial, under the age of 2, otitis, 10 days is superior. Strep throat is an enigma. It's confusing to people. It is true that there are trials that show if you dose penicillin 3 times per day orally, 3 to 5 days is inferior to 7 to 10 days. However, if you use oral cephalosporins, or if you dose the penicillin 4 times per day, shorter durations were as effective as longer in randomized controlled trials. So it's a little bit complicated. Now, before we wrap up, and we are in the home stretch here, There are a few common questions that I get asked. So let's get these out of the way because I get asked them every time I give this talk. The first question is, are you really telling us that you can never treat antibiotics for longer durations? And my answer is no, that's not what I'm saying. We're talking here about the average. We're talking about the normal. We're talking about a mean distribution, right? We're shifting the average typical case to shorter. Doctors must always be able to customize the duration of therapy based upon how their patient is responding. So it's not that you can never give 10 days of antibiotics, it's that the average should shift from 10 to 14 to 3 to 5, and you would be giving 10 days in unusual circumstances for patients that are more complicated or not responding well to therapy. And then I get a series of questions, typically that I call the what about questions. Yeah, but what about typhoid fever? What about chronic prostatitis? What about non-tuberculous mycobacteria? And they come up with a bunch of these what abouts. What about all these? And my answer is, yeah, what about them? I have an undeserved reputation as being a maverick. It's truly undeserved. If I don't have data, I look like this. I only look like this when I have data. Okay. So I don't know how long to treat typhoid fever and non-tuberculous mycobacteria because I have no randomized controlled trials to tell me. I hope somebody does those trials so we can answer that question. In the meantime, I'm only here to tell you what the trials show. I cannot tell you the duration of therapy for things that have not been studied. We'll end with this. This is the last sort of concept. Who amongst us has not said this or heard this? If you want to prevent resistance, take every last dose of antibiotic your doctor gives you, even after you feel better. Isn't this one of the most universally believed things on planet Earth? And it turns out it's complete and utter nonsense. Okay. And it was in the same lecture in 2008. Lou Rice pointed out this is complete and utter nonsense. There is not a single shred of evidence to support this concept. It flies in the face of everything we know about natural selection. If you want to watch resistance emerge, come to my laboratory and we'll do a serial passage study. Each additional day we passage the bacteria and antibiotic, there is a higher frequency of resistance. That's how natural selection works. This is nonsense. And the origin of this nonsense, Dr. Rice traced to a misunderstanding of a uncontrolled case series of penicillin therapy published in 1945, in which the authors wrote in the discussion that they continued antibiotics after improvement for 2 to 3 more days to try to prevent relapses. But they were actually not preventing relapses. They were preventing infections by new strains. And we know this because they actually serotyped the strains, and the second infection was caused by a serotype different than the first infection. So this urban legend, which everyone believes in and is totally wrong, is based on a misunderstanding of uncontrolled data published in 1945. Here's the real point. We need to stop saying this to patients, okay? If somebody's better, they don't need to keep taking their antibiotic. Perhaps more importantly, if you give somebody 3 to 5 days of antibiotics for their kidney infection, they're not going to be feeling totally cured at the time their antibiotic stops. That problem comes up if you give them 14 days of therapy. Yeah, day 7, 8, 9, they're going to be great, and they're still taking antibiotics. If you give people short course therapy, it obviates this concern in the first place. So, in conclusion, we really do need to be much better at preserving the antibiotics that we have. We are terrible at this, and we need to become much better. We have data from multiple randomized controlled trials across multiple diseases that we have been treating for too long. 3 to 5 days in most cases is adequate for most types of infections. And you don't need to keep giving after that. And if you do, you will only select for resistance and cause adverse events. So the bottom line, and all you really need to know from the last 30 to 40 minutes of pain you've suffered from with me, is shorter is better. And with that, I will stop and open the floor to discussion.
Talk. So The floor is now open for questions from the audience.
Hey, Brad. Good evening. I'm
Good
Abdul
evening.
Kafoor.
Abdul, how are you?
Great. Brad, you are a maverick and we respect you for that. Oh, Brad is one person in US or the global infectious disease world who have the courage to question and challenge the academic industry cabal that is controlling the field of infectious diseases, including myself. You should learn more about Brad, read more about it. A very courageous person in the field. And he had the courage to question Infectious Disease Society of America, his own society. And that's what is called as courage, because we are living in a world where the so-called evidence-based medicine is industry-influenced evidence-based
Yes,
medicine. But when
yes.
people like Brad speak about evidence-based medicine, you can believe that is the evidence. Thank you, Brad.
Abdul, namaste. You are too kind, and seriously, you are an inspiration, my friend. It's good to hear your voice.
Hi, Brad. This is Gaurav.
Hey,
Uh,
Gaurav.
Hi. So, getting you to agree for this talk was almost as challenging as convincing the clinicians to stop antibiotics early. But I guess both are worth the effort, and thank you for being here. So, I have two questions for you. First is, what are the biggest challenges, in changing the clinician's mindset and practice patterns from the traditional complete the full course approach to adopting a shorter evidence-based antibiotic duration?
Yeah, I mean, I think that's sort of the key question, and I think the answer is habit. Like when you train, you learn a certain pattern of practice when you train. You tend to keep doing that same thing year after year after year. And it's really hard 10, 15, 20 years later to change your habit. So it's inertia, it's habit, and then it's myth. Those are the two problems that we have. There is a myth that what we learned during training was based on data. We just assume that that's the case. When you start asking, what are the data that's based on? You start peeking behind the curtain, it's actually kind of surprising that a lot of what we were taught was never based on data in the first place. So I think those are the two things we have to overcome psychologically. The habit of what we learned years ago and accepting that what we learned years ago actually was never based on data in the first place.
Yeah, thank you. And last,
Sure.
uh, do you think reducing the duration of antibiotic is actually help us to reduce antibiotic resistance in oncology setup like us?
Yeah, I think it's highly likely that it will. I mean, in randomized controlled trials, it's been repeatedly shown that if you sample the site of infection afterwards, you'll have decreased resistance emergence in the patients who got shorter durations of therapy. So I think it's highly likely that if it systematically was adopted, you would encounter less antibiotic resistance in your patients.
Yeah. Thank you, Brad, for staying awake for me.
Thank you for the invitation, Rob.
Yeah, one question. So we have time for two short questions, perhaps.
Hi, Dr. Svelberg. This is Priscilla. I'm an infectious disease physician from Christian Medical College Fellow. So my question is this. I mean, for febrile neutropenia, other conditions where you can clinically make out a patient is better, it is more difficult for something like an osteomyelitis, a chronic osteomyelitis.
Mhm.
So convincing physicians, when you cannot actually make out what's happening in the bone there, it's
Mhm.
really difficult. And that's when I think the major challenge is for us to, convince them to give a shorter course of antibiotics. So what do you do? And how do you convince them to stick to something less than, 10 to 12 weeks? I just wanted your opinion on that.
Priscilla, thank you for that question. I feel your pain. Um, it's really hard to change practice. And when you start, people will beat you up. Okay. I many times people yell at me for oral therapy and short course therapy, and I'm like, all right, trials, randomized control trial. I understand it's upsetting to you. I understand it's distressing to you, but we have so it's unfortunately I'd like to be able to tase people. I've requested privileges to just go around tasing doctors and stuff, but I haven't been granted privileges to tase yet. I've asked for it, but they haven't granted the tasing privileges yet. So what I'm left with in the absence of tasing people is nagging. It's persistence. So what I say is, look, draw inspiration from the movie Finding Nemo and the character Dory in Finding Nemo. Just keep swimming. I know it's hard and people get upset, but if you just keep swimming, eventually you'll turn the tide. Eventually, and it may take years. It took 15 years for shorter is better to become more standard in the United States. You just got to keep swimming and you just got to keep showing people the data over and over and just persistence. Sadly, I wish you could tase people. If you get that permission, can you let me know? Because I'd like to be able to do that. Absent that, it's just persistence.
Hi, Brad. This is Manju here. I'm a medical oncologist and I treat hematological cancers. Thank you for reinforcing what I've been trying to get into the team as well as others, that we are treating the sickest patients, but it doesn't mean that they need 14 days or 21 days of antibiotic. So thank you so much for reinforcing that. Two questions I have. This is more from what I have seen in practice. If you have an MDR, proven MDR bacteremia and sepsis, do you think that that would change the total duration of antibiotic? That's my first question. The second question, which is, which I find very difficult to convince many of our colleagues, any role of any of these biomarkers, whether it's CRP or procalcitonin, to decide on the duration of therapy. So these are
those are great questions. Thank you for those questions. I don't think that, quote, MDR has anything to do with duration. The key is, do you have an active antibiotic? It always baffles me. People are like, well, this is an ESBL. I have to treat it longer. You have meropenem. It kills ESBLs just as dead as ceftriaxone kills non-ESBLs. It's no different. Do you have an active antibiotic? And if you do, the duration should not need to change. Now, to the second question, I lost my train of thought. Second question, remind me.
Second question was, do you need any biomarkers to
biomarkers,
decide on the duration
yes.
of therapy?
Okay. So I hate sed rate and CRP. I hate them. I hate them. I hate them. We published a paper just a few months ago calling them zombie tests. They come after clinician brains to munch on clinician brains. No matter how many times people publish that they don't work, people keep using them. You just can't kill these tests. Like them. They're useless. And there's data to show that. Now, Procal is more nuanced. There are now 20 or so randomized control trials. And the way they did these trials is they randomized the doctor, not the patient, to see the result of the Procal. And they gave them an interpretive algorithm. And they didn't have to follow the algorithm. They could ignore it if they wanted. And in 25 randomized controlled trials, mostly respiratory tract infections, but there's sepsis in there too. The doctors who got randomized to see the Procal result used 25% less antibiotics. And there was less adverse events as a result. Now, one of the criticisms of these trials is the duration of therapy in the control arms were pretty long, and that's legitimately true. Like if you're going to give 3 days of antibiotics for acute-acquired pneumonia, I'm not sure you can shorten that by following a procalcitonin level. But the way that I use these trials, and this is where it becomes nuanced, is for the psychology of it. So a patient comes in and they have a pneumonia and the Procal's low, I'm like, that's probably a viral pneumonia. 60% of pneumonias now are viral, right? So maybe I don't have to give antibiotics at all. And the docs are really scared not to give antibiotics. The way we steward the test and say, look, you sent the Procal, it's low, right? It's reassuring. So I think it can provide a psychological reassurance to reassure doctors that are really scared to stop, that they can stop. I don't think the use, therefore, is so much serially over time as, is this an infection that requires antibiotics in the first place? And there I actually have found Procal to be useful. And I know this is a little controversial, but I'll tell you, that's our local experience. What's your experience been?
Thank you so much. What I feel that many times we rely on these biomarkers because we are not seeing the patient. So if you were treating patients remotely, I think CRP PCT values will help us in deciding what therapy. But if you are examining them bedside on a daily basis, I think your clinical judgment and the patient's well-being will tell you when to stop rather than PCT and CRP. So that's what so I would love you for that, what you have said, and you've made my ear, if not the day.
I couldn't agree with you more. Well said.
Okay, so the session, we are running late, but I still want to exercise the power of the chairperson and ask one irresistible question, at least as far as I'm concerned. So, so you could convince the audience, Dr. Spellberg, that short course is better than long course. But how short is good enough? I don't think that kind of emerged very well, through the talk. So, and I saw that it was still moving in constant units. For 2 weeks versus 1 week. But how do you know that it's not 3 days? Why should it be 7 days?
Yeah, no, that's a great question. And the key is you got to have the trials, right? I mean, and so for pyelonephritis, it was 7 days. The first few trials were 7 versus 14 days. And then there were 5-day trials showing that 5 days works. 3 days may work. Nobody's done that trial. So I think we just have to follow the evidence. We have to see what the trials show. There's going to be a point of diminishing returns. Like, is 4 days going to be really, should somebody do a randomized control trial of 4 versus 5 days? There's a point at which you get it's so short that I'm not sure it's worth shortening much more. But I think you're exactly right. Just because we know 6 weeks of antibiotics is adequate for osteo doesn't mean that 4 weeks won't be.